Welcome everyone to today's webinar, Unmasking 2021, How 3 Health Systems Are Revamping Their Revenue Cycle Strategies. I'm Morgan Hafner with Becker's Hospital Review. Before we begin, I'm going to walk through a few housekeeping instructions. First, we will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Second, today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. And lastly, if at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. And with that, I'm happy to start today's webinar by introducing our presenters. With us today are Greg Arnold, the Vice President of Revenue Cycle at Edward Elmhurst Health, Chris Bergman, Chief Financial Officer at Dayton Children's Hospital, and Heather Schneider, the System CFO at Penn Highlands Healthcare. Joining them is John Talaga, who is the Executive Vice President and General Manager of Healthcare at Flywire. At this time, I'm pleased to turn the floor over to John to begin today's presentation.
Thank you, and everyone that's taken the time to join today during I know there's always a busy week and heading into the holidays, so thanks for joining. Just really quick, just on a quick introduction to Flywire. Flywire is a global payments company. We focus on solving complex payment problems in complex industries. So that includes education, higher education, as well as, of course, healthcare. And in healthcare, we manage about $10 billion in patient responsibility on an annual basis. And about 30% of U.S. households make payments through our platform. And we work with 4 of the top largest and top 10 U.S. health systems in the country. So today, we want to focus on a couple of key things with these learning objectives, and talk just, very briefly. I'm going to hit on some interesting stats to set the stage for the panelists. Then we'll go into the panel discussion, which will focus the rest of the time. So just hitting on some of these things, as we all know, and nobody needs to even be in the industry to know what's going on, but it's certainly been an incredibly pivotal year. And I think what you'll hear from the panelists is, how the things that have happened in 2020 have impacted their planning and execution, both during the year of 2020, but also heading into 2021. And when we look at the key things that are, sort of impacting or affecting healthcare in 2021, some of the things we'll touch on during this discussion is certainly the continuing surge in COVID-19 and how that's impacting not just the clinical side, but administrative. We're going to talk about the CMS mandate, transparency mandate, look at the rapid onset of digital adoption, which is something that is continuing to drive into the industry with these impacts. And of course, the affordability problem in healthcare, which has really become and continues to be a crisis. So just 2 pages quickly on some stats that will help add some context. First of all, when you look at, there's 75% of new users for online and digital. So it may sound crazy, but really what COVID's done is it has really created a lot of new users that would otherwise maybe have gone to brick and mortar, made, received statements and things like that via paper and made payments via check. So there's new users, and then 37% are increasing the amount of time they spend online. And that's no surprise. I'm sure in everyone's own households, you're experiencing things like people spending more time online since they can't leave the house. But that is also providing a lot more opportunities to build more meaningful relationships and connections with customers, and in this case, patients. Then when you look at also the number of total consumers that are using digital post-crisis, 29, almost a third. This isn't just a COVID-19 issue. This is going to continue. These changes are going to impact and continue on post-COVID-19, and there will be an end to that. So the affordability crisis, well, this has been a crisis, nothing new. It's been exacerbated with COVID, no doubt. 43% of U.S. adults are underinsured, and then you have almost 13 million of Americans that have lost their insurance through their employer, which really certainly creates an issue and financial strain. And then we look at 37% of Americans have reported that medical bills and medical debt has completely depleted their savings. And that's a startling number and really a sad number, really, when you look at it, because we work so much on getting collections paid, and there's some that just can't pay, but those that are paying are sometimes depleting their savings. And then the last one is almost half of Americans, U.S. adults, are putting off care because of the fear of cost, and that has many downstream impacts on the clinical and health side of our country. So let's get into the panel discussion. And we already did the introductions, but we have a tremendous panel today, and really excited to get started on some of these questions. And we got Chris Bergman, Greg Arnold, Heather Schneider. So I'm going to let them just take and introduce their organization and themselves in a little more detail, and we'll start with Chris.
Thanks, John, and welcome to everybody out there in virtual land. Thanks for tuning in today, and hopefully we can share some things that we're doing that might be useful to you. I have, as John mentioned, I am at Dayton Children's Hospital. Just a little bit from my perspective. I have actually been in healthcare for 40 plus years. The last 25 has been on the hospital side, of which 20 was in the adult world, and the last 5 has been in the pediatric setting. So I've got a little bit of a unique viewpoint from both sides of that world. Dayton Children's, we've been at Children's Hospital for a little over 50 years. We've been actually in the healthcare business for 100 plus. Interesting enough about Dayton, a lot of technology here over the years. We're kind of coming out of a valley right now in Dayton, but obviously first air flight here, car starter, cash register, all got invented here in Dayton, Ohio, interestingly enough. So we've been here serving the kids of our region. We're a little unique in the children's world in that we have huge competitors both to the east, to the south of us, and in a lot of markets, the children's hospitals tend to be kind of a monopoly or on their own, and we have a little bit more competition, which actually serves us well. It helps us stay a little sharp. And over the last 5 years, a little bit of a renaissance here to try to bring us into the 21st century, and we've really changed our game and upped our game in so many different ways, including the revenue cycle processes that we have in place. I'm happy to chat a little bit more about those today.
Thanks, Chris. Greg?
Hey, thanks, John. This is Greg Arnold. Happy to be here. Seems to be the new norm that we seem to have calls all virtually today. So Edward Elmhurst, we're a 3-hospital system here in the southwest suburbs of Chicago. We employ about 8,500 employees, 2,000 doctors, nationally recognized for our heart hospital, have a comprehensive cancer center. We are magnet recognized from a nursing standpoint. I'm actually fairly new with the organization, joined in March. Some say that I brought COVID on to the organization, but happy to be here to help them through that. And I've been in pretty much rev cycle my entire career, both on the vendor side and the provider side. So I think I have a pretty interesting perspective from both sides there. I appreciate you joining today.
Thanks, Greg. I'm pretty sure you didn't bring COVID, but
I know I didn't. Thanks.
We're trying to blame somebody. Heather.
Thanks, John. Hi, I'm Heather Schneider. I am the System Chief Financial Officer for Penn Highlands Healthcare. Started my career in healthcare in the late 90s in the for-profit world. Spent a lot of years in the for-profit side and made the switch over to Penn Highlands in 2019. You can see that the system actually is a very young system formed in 2011. We're a rural western central Pennsylvania system. Basically the whole continuum of care. So we start at physician practices, run through 6 acute care hospitals, including some critical access hospitals. We have long-term care, skilled nursing facilities, and go all the way to home health and hospice. What you will see about us that makes us a little unique besides our rural nature is we work off of a hub and spoke model. So we have a hub hospital in Du Bois, Pennsylvania, which I believe is on the next slide. If we could get that advanced, it might help folks to get a better idea of where we are. So in the middle of that green circle, you will see a town called Du Bois, Pennsylvania. So we are between Pittsburgh, State College, Pennsylvania is to our east, which is where Penn State is located, and Philadelphia is a good 4 hours to the east of us. So we're truly in a rural area. And what we do is we help those communities, especially in that green area, now expanding out to the blue area, to take their small rural, sometimes critical access hospitals and be able to get those patients to a tertiary care facility basically a lot closer than in some of the major cities in PA. And happy to be here and start to talk about some of the things we've done in the last couple years to bring us a little bit more out of the woods personality and into the new century.
Excellent. Thank you so much, Heather. Well, let's get the discussion kicked off, and I'd like to start with presenting all the panelists with a question. So, health systems have often have multi-year strategies for how they want to improve the revenue cycle processes and financial outlook. Tell us a little bit about what your original vision for 2020 was, and what your original vision for even 2021 was, and how you've had to adjust following the pandemic. So, Heather, maybe we can start with you.
Sure, happy to start that. So, starting out 2020, it was my first full year to start here at Penn Highlands. So I had some very aggressive things I wanted to do, first of which was to increase our point of service collections. Basically, no one had really focused on that for years. It was a new concept. Wanted to start educating the public and our employees and physicians on why it was important and necessary for our system. Unfortunately, of course, when COVID hit, the last thing people wanted to do was pay us money up front. But what we did is we continued on down the path of we were putting in some estimation software because that didn't exist. So we went ahead and fully implemented that. We ended up delaying our Flywire implementation because of the little bit of the delay, but had that going into work because we wanted folks to be able to consolidate their bills and try to get some more people in our rural communities to use their online resources. The other thing that was interesting for Penn Highlands is we had some very aggressive strategic planning that was on the docket for 2020. There was a large bond issuance done here in 2018 before I got here. So we had to continue with those because we obviously had bond covenants where we needed to build in a certain amount of time. So we had to shift our focus away from why we were building and explain to folks why we were continuing to build. So, you see things like furloughs going on in the community, and we had to explain why we were continuing to do construction where we might have people in the surrounding area furloughed. So lots of things changed, but lots of good things happened as well. We were able to expand our vision into some of our secondary markets where folks needed our help as a stronger system to uplink to, and that ended up bringing us to our 6th hospital, which we actually affiliated with November 1st in the middle of this crazy year.
Great. And Chris, with some of the things that you are looking at for your plans and how they've changed, how has that been impacted in the children's hospital environment?
Well, interestingly enough, John, in the children's world, we saw the same sort of decline immediately after a lot of the shutdowns started occurring. We saw the same sort of decline in business with quote-unquote elective procedures or non-emergent procedures. So our business dropped 40-50%. But as the country started to kind of unlock and open back up, our business has come back, but not nearly to the extent that some of the adult hospitals are. Of course, adult hospitals are seeing a lot of COVID patients right now. From a strategic perspective, I think we're a lot like Heather's. We had a lot of plans, particularly on the point of service side, We had, when I got here 5 years ago, we had no revenue cycle processes. We had the medical records department pushing a lot of paper around, and we had a billing group that with a huge denial rate going on. And so we've spent a lot of time the last couple of years with people, processes, technology. We didn't have good deployment of technology to help us be more efficient, more effective at what we're doing. But this year, we continued on the same path as some of the strategies, particularly related to denials and prioritization of accounts. Probably the biggest thing that we changed was some of the digital strategies, and I know we'll talk a little bit about that later. But we had to really pivot real quick and start going to touchless registration points and things like that, as people didn't want to come to hospitals, and they certainly didn't want to go wait in the old-fashioned waiting room. We always laughed at that, the Seinfeld episode always comes to mind. You think about waiting rooms. Is why the hospital put you in a waiting room? Because they have a waiting room, right? I have to use it because I have one called a waiting room, so I got to make you wait. But we tried to move away from that, and we certainly had a huge explosion of the virtual visits, and we'll chat a little bit about that later. But I think the big piece was accelerating the digital component with our consumers. We are different from the adult world. We have kind of one group of people we deal with from the guarantor perspective, whereas the adults have a lot of different folks in the different age generations. We have a lot of millennial parents, and so they don't answer the phone, they don't answer email, they might answer a text. They want to do everything digitally, and quite honestly, as hospitals, we're just not prepared for that, right? So we're not prepared to take payments and text and a lot of things like that. So we've had to really kind of shift our focus to turn on more of those products as we've gone down this path.
Excellent, thanks. It's funny you say that about the waiting room, because that's one of those things we hope doesn't return back to normal after all this, right?
Absolutely. We got some beautiful waiting rooms that we've got to redo now.
Yeah, that is true. Greg Arnold, how have some of the plans and things changed at Edward Elmhurst?
Yeah, no, similar to what Heather and Chris kind of talked about. I mean, I think clearly on our side, and Chris mentioned this, was how do we accelerate some of the things that we already had in our fiscal year 20 plan and make sure we start doing those things that we thought we were going to do in 21, start doing those now. So we were exploring touchless, technology, service delivery, the virtual visits, certainly how can we expand upon that? With COVID testing, we started to do we built a stand-up drive-through. So then the question is that something that we actually should make more permanent into our organization and how we deliver care? We're expanding the virtual and digital front door strategies, the waiting rooms that, work with the physicians and ambulatory locations to make sure we're enhancing the patient's access to the care. So, certainly we're looking at, what are all the online options that we can do? How can we expand access to visits so that you don't necessarily always have to call to schedule things? Are there things that we can allow you to do on your own, through your phone, through your computer? And so how can we, anything that's related to that, how can we move that forward? And then, certainly, we want to maintain our person-centered culture, to ensure a kind and memorable experience. We come up with the motto that, everywhere else it's healthcare, here it's personal. And so what are the things that we can do to really make the experience for the patient personal to what they're experiencing here? I don't think really any different than what the other three are doing, or really many of you out there are doing, but really trying to look at things that we can accelerate to bring forward so that we can, meet the COVID demands, the new normal, as we call it.
Yep. So that's always really interesting to me, as I work with, and my team has worked with hospitals. When you really get into it, we have such a small sliver of what all the things are that are going on, right? And it always blows my mind as to how many different initiatives and projects are really out there, and what you could do. So how do you prioritize these different projects and initiatives, especially with some of the changes going on? Like, there's certain types of categories or projects that you're more likely to undertake than others right now with everything. Or so Heather, maybe you can start on that one and give us some of your insights.
Sure. Number one for us is we have to continue to execute on our strategic plans, particularly with the 2020 bond construction. We're we're pushing up against the end of the 3-year period, so we certainly have to execute on all of those. We have to continue to help systems to uplink, as I said earlier, with a larger facility when they need us. But most importantly for us is anything we can do to keep people local for their care. Folks aren't wanting to obviously travel too far away from their home, and in a rural area that can be difficult from time to time, so we are trying to bring those services to them, be it virtually or not. The other priority that I'd say was very important to us is getting any kind of efficiency out of our system without burning into our cash flow. Anything we can automate is very important to us. But as I said, we don't want to outlay a whole lot in order to do it, knowing that cash is very important at this time. And to that point, when we were in the peak in the spring of COVID, we didn't delay any of our revenue cycle processes or deliberately didn't restructure any of our revenue cycle folks so we could continue with that cash flow. So that's how we've prioritized.
Got it. No, that's interesting. And Chris, what about you in terms of prioritization?
I think that for us it was, I guess we're trying to think about the whole consumer side because people were so afraid. So like our business, like I said, popped back, but it isn't totally back. And when you look at SG2's predictions, they're suggesting that it may not totally come back, particularly in the ED world. On the pediatric side, people figured other things out. But there's also, as you mentioned earlier, John, kind of delay of care. So what you're trying to do is how do we remove barriers from a couple perspectives. One is how do we make sure we communicate that the place is safe? Like the hospital's safe. What do we do? And we were very focused on, even in our screening stations, being very visible about showing people we're cleaning things, we're scrubbing things down. We've got visibility around that. So when somebody comes, they actually think, okay, this is a safe place to be, and I'll come here because we need to get your kids in and have normal things that they need to be seen for, right? And so we were trying to focus on those things priority-wise, and then I think this how do we get people in quicker, and the touch-free registration points. We even went to some of the online scheduling, but also even predictability on no-shows. Like how do we predict how many no-shows we're going to get, and so that we can schedule appropriately, kind of like an airline does. And so that way you can maximize the number of patients you get in, you maximize efficiencies of your providers. There's really a consumer focus on the priorities because if we can take care of them, and then obviously as a finance guy, you got to make sure we collect cash, right? So we've got to focus on cash collection techniques, but it's really about trying to make sure that we left the portal out there for patients to come in, however it happened to be it virtual, be it in person, make sure we were safe, keep our sites open, make it safe for them to wait, et cetera. That's kind of how we weighed our priorities during those last 9 months.
Excellent. Yeah, and I've often, you look at any business, it's difficult to change priorities in the middle of the year because of, uncontrollable circumstances, but it's been amazing, I think, how all the hospitals have done an incredible job of doing that this year. So,
one thing too, John, I was going to say
yeah.
that Heather touched on was, even like getting back to doing the things you were going to be doing, right? So we were talking about going down a value-based care strategy and some other primary care strategies, and you kind of almost had to force yourself back into the fact that I got to get back to normal business too at some point in time. I got to take care of the new things, but I got to get back to normal business because I can't let that stuff slide. So sometimes that was as hard as anything, is to get back to just taking care of business as usual.
Right. Yeah, it makes a lot of sense. And it goes to the clinical side too, wanting to just get back to regular, elective procedures and things like that as well, right? So with, kind of going off priorities, there's also, some of those things you don't control and some things you don't have the option to prioritize. So, the CMS mandate for price transparency, is coming out is required in January. So how are you preparing your organization for the CMS rule coming out here? And I think this is something that everybody's dealing with, and some are, just give you a quick example, we work with, Guidehouse Consulting, and they said that there's some customers of theirs that are saying, we're just going to take the penalty because we don't want the way they're requiring us to show chart
Are we still connected?
Yeah, we're still on. Hey, everyone. Just want to hop in for a quick second. We're addressing some technical problems. Chris, I think that was a really fantastic question, and I wonder if Greg, if you can still hear me, are you able to address that one?
Yeah, no, most definitely. So if everybody can still hear, so the price transparency one's an interesting, depending on where you're at. I know many hospitals have already had their charge masters, out there on their websites that you could look. Now, this certainly is a next level. Fortunately for us, we're actually an Epic house, and a lot of kudos to Epic and our IT team. They've worked really hard to actually, get this up and running through the MyChart app, which has been great. We will be ready. Actually, we'll be ready in the middle of this month to be able to do the 230, and we picked the 230 top services that we provide to put out there, and then the 70 required. I think as an organization, we're still discussing in terms of, how transparent is, John, as you wrote. I know some people are willing to just take the fine and so forth. I'm not sure we're there to that point yet. We know we'll be ready, and I think we'll probably make a game time decision in terms of, when we turn that on and what we're going to do there. So that's been my take on it. It's been that one, unfortunately or fortunately for us, has been pretty easy with the help of Epic and the IT to get that going. And then the fact that we actually had, prices out there previously.
Excellent. Can everyone hear me again? Greg, can you hear me?
Yeah, I can.
Yeah, sorry. I disappeared there for a little bit. I apologize. Thanks for that. And Heather, maybe you can give us your insights on the mandate as well.
Sure. So we vetted a lot of options here, one of which was honestly whether we would want to just take the penalty. We looked at our national accounting firm to see whether they could help us out. But at the end of the day, we ended up using the company that did our pricing estimator for us. Since we had already loaded all of our contracts with them, it turned out that was a very easy solution, and they got us up and implemented in record time. So we're ready to go for January 1. So we kind of lucked out with that we did all of that this year.
Excellent. And, I keep hearing that. That's interesting because, rather than just put the charge master out there, of actually applying the estimation to it, there's so many that just weren't quite ready for that. So is that on all of the shoppable services you're able to do that for, or just some, or how's that working?
We are able to do it with everything because we fully loaded all of our contracts when we did the estimation tool.
Excellent. Very cool. Okay, well, let's shift a little bit, and we've talked a little bit about it with these other topics as well as the digital. So obviously we've seen a huge, radical uptick in the digital habits, participation, and really just expectation of patients. So one of the things that you may have seen on that first slide that I showed, McKinsey did some research, and they say with digital adoption has vaulted 5 years just in the last few months since the pandemic. So how has your organization, and we'll start with Chris, how's your organization adjusted to this shift in digital and that the pandemic has kind of vaulted forward?
Well, that's a loaded question because it's like yeah, you kind of get forced into it. So just the quick thing is on March 13th, which is the day our governor announced all the shutdowns in Ohio, we were doing 30 virtual visits a week, so none basically for all practical purposes, and we went to I think we went to like 14 or 1,500 a week, like 2 weeks later. And we went from nothing to something really fast. Now we're down to about maybe 300 or 400 a week. So we went back down, and I think that the challenge we had, there's a couple things there, is that, one, when you're forced, the only way you're going to see your patient is through the virtual visit. Doctors are willing to figure it out, right? Plus, they weren't balancing personal visits with virtual. They were all 100% virtual at that point in time. I think the challenge we have is it's like anything. You change a process, and people have a hard time changing. And then physicians are no different than that. It's that they have a hard time, this slot taking a patient that's actually in their space, and then the next slot's a virtual one. They have a really hard time toggling, and there are some valid reasons why that's the case, and there's reasons why it's just because they don't do it. And we still have that generational difference in the guys that have been doing this for a long time, and they're in their 50s. They're the harder ones to adopt that virtual piece, and then those younger guys, that this is just their world, they got no problem. So we're still on both sides trying to sort through it. We have some hardware issues because we not to get into a lot of details, but inside of physician options, we had essentially dumb screens, if you will, that were just connected to Epic. Well, you can't do virtual visits and do all the things you need to on those. And so a lot of it's got to switch out hardware and software. We had the right platform, fortunately, so we were able to step up and do it. So it's not a total technology issue. A lot of it's workflow and getting people to understand that our consumers still really want to do more things digitally and less things face to face. And we're still trying to find the right place for that to fit. So there's certain things that naturally fit, certain things that don't, and there's a bunch of stuff in the middle that we haven't quite solved yet. We have a digital consumer digital experience group looking at all the different components, and I think we're on the right track. But we're not there yet. We're better than we were pre-March 13th, but we're not anywhere where we could possibly be as we look forward.
Great. And Greg, some of this sound familiar to you, or what are some of the key things that Edward's been doing?
Yeah, no, most definitely. Certainly the telehealth. I mean, no need to kick that can. I mean, that we're all looking at that. From our standpoint, being an Epic MyChart, we're working to see how do we increase our texting communication that we do with the patient. We're expanding the On My Way capabilities. That's the Great Clip. I call it the Great Clips app, where you just kind of, tag that you're going to come in and know that. So we're trying to expand that beyond urgent care so that we can expand it with lab and other things to make it from a digital standpoint. We are looking at the, what we're calling hospital at home option to be able to, for those patients who aren't as severe, are there ways to actually get them and monitor them, from our corporate office or the location within the hospital and monitor them at home. In our ED with COVID, we're sending patients home with pulse ox and so forth, things that we normally might have admitted them for observation. And so we're trying to think of ways that we can, technology to send them out to that we could monitor. And then, selfishly from a rev cycle standpoint and thinking about our patients, we are thinking about technologies like what your company provides, regarding our patient financial interactions, and how do we set up payment plans that are fact-based, not just a peanut butter spread across, a wide spectrum, being very specific so that we're customizing the patient experience. And working at other companies that also will help us provide that both from a clinic and financial standpoint. So those are some of the key things I think that we're looking at.
Good. Peanut butter spread. So I'm hoping you haven't trademarked that. We can use that, right?
You can have it. Nutella.
Sounds good. Hey, so Heather, I'm just curious. Like you showed that kind of the heat map of where Penn Highlands is. Have you seen your location in the community you serve being different than the larger metropolitan areas through all this with respect to digital, or do you see kind of similar problems and challenges?
We had similar issues, but we had the same kind of adoption, if not probably larger adoption than some of our metropolitan counterparts. Just as an example, we used to do less than 100 virtual visits a day, and we ended up in the month of May with like 11,000. So obviously we saw that adoption. The biggest issue in our area is truly internet connectivity for folks. So we ended up doing a lot of audio calls versus more of the audio visual type calls. But the same type of issues happen here.
Yeah. Excellent. So want to kind of turn the discussion a little bit to, we talk about digital and all of these priorities that have changed, and, always kind of turn the focus back to the patient, right? The patient, when it comes to payments and their affordability, as I mentioned, has been really a crisis. And with the pandemic having exacerbated this, we're just seeing, more solutions than ever before that are needed by patients to make payments. And there's lots of options out there. So how are you, and, why don't we start with Greg, how are you preparing, or what are you doing to meet this challenge while still driving towards your key business objectives?
Yeah, so, as I talked about, solutions, such as yourselves and others, in terms of where we could really make sure that we're designing a payment for the patient that fits what they can actually do, so that we're not just, putting one size fits all. I mean, we really are trying to look for solutions that will help us in those cases. And then we're also just looking at how do we actually deliver care too in a more cost-effective way to our patients. I had talked about the drive-through. That's a relatively less cost in terms of how you set up some of those things. You don't need the large infrastructure that you need at some of these other sites. And so we're actually looking at how do we make that a more of a permanent solution for our patients to be able to do. We were doing things beyond COVID testing through a drive-through that we think are more cost effective, and we should be able to pass that savings back to the patients. And then, again, also looking at things that we do to the patients from an inpatient, the hospital at home, if there's things we can do from more of a, outpatient level to rely on, less of their insurance benefits, we want to try to pursue that. And then finally, I think we do have a big focus on analytics, right? So how can we take as much data and learn from that? And so that's been a big focus for us, is be able to, how do we derive as much knowledge from the data that we already have.
Right. And some of the things that traditionally, like payment plans and, getting patients to pay or discounting and things like that, have been very passive, right? It's almost been like waiting for patients to complain and negotiating, or just letting your collection agencies do it. So, sorry, Greg, just throw it back to you. Like, what are some of the things that you're doing? Like you mentioned, the analytics, profiling your patient. I know it's been a key thing for you. And is that going into 2021 something that you feel you can change, going from passive to more proactive?
Yeah, no, most definitely. I think we need to understand the patient's ability to pay. You need to be able to look back at, what's their likelihood to pay, and how much effort you exert on that patient. In terms of your calling campaigns, can you send more stuff electronically through text, email, and so forth. So I think certainly stratifying your population that way. And then I think, being able to just offer options up front, so that when the patient logs in, they know instantly what their options are, as opposed to them having to ask for it. And actually taking back more of that control here. I think many of us in the past have outsourced that to, third-party vendors to do that. And we envision doing that more on our own, and using, software to help us do that. So I think those are some of the key things that we're trying to focus in with that technology.
Heather, how about you? Did some of the things that Greg's saying apply, and what are some of the other things that you're doing to focus on this? Yep.
I mean, I can literally echo almost everything that Greg said. The one thing that I would add to that, that I hear a lot in our rural area, more than I have in when I've been in more urban settings, is that patients don't necessarily want the human interaction on negotiating payment plans and that type of thing in a small town, because they're embarrassed, quite frankly. They don't want folks to know that they're having trouble paying their bills one way or another, or maybe they have old accounts outstanding, and it's hard to talk to your neighbor about that. They're a little insecure about that. So we're very excited about the options that they're going to have online to go in there and create their own payment plans and combine their accounts. And that just goes along with everything else that we're being able to offer digitally.
Great, thanks. And Chris, how about you and Dayton Children's?
I think a couple things. I think similar to both Heather and Greg, but I think there's a couple of things. One is there any ability to package price something? And we've tried it on a couple of things, like in our world, ear tubes and tonsillectomies and things like that. So a consumer knows exactly what the price is, and they don't have 7 different bills showing up. I think anything we can do along those lines to simplify a package price for something, a bundle or whatever you want to call it, I think really helps. I think the second thing is offering low-cost solutions. So we opened up a series of what would be best termed as pediatric minute clinics, which is kind of so you're looking for that market niche that doesn't exist, right? You're looking for something that no one's doing right now, and it was something we're doing. Everything's generally less than $100 when you go there, but it's all low-end stuff you might need to take your kids for. So we've got those out there. You don't have to go to the grocery store or Rite Aid or whomever to go to a minute clinic for your kids now. You can actually go to an actual pediatric minute clinic. So those sorts of things are their consumer offerings that are low price, easy access, and that's a nice place to play. And then once you finally get them in the system, I think the tools, we've been pretty happy with the tools. Not that this is an advertisement for Flywire, but just the tool of having that on the very front end of the process that people can go immediately into a payment program and not us do the traditional 90 to 180-day dance with them, only get them to a payment plan 180 days from now, which is the least likely you're ever going to collect on that $50 a month at that point in time. We'll get to them right up front when they've done the service. So those things that we're getting in front of them quicker, offering more easily understandable pricing, and then also just that low price, easy access component, I think is all great from a affordability perspective.
Excellent. And, I'm really curious, Heather, you had mentioned doing some of the estimations on the price transparency side with the shoppable services. I know it's not like that, well, maybe it is implemented yet, but I'd love to get everyone's thoughts on how they feel providing an estimate up front for the patient's expectations on what they're going to owe impacts their ability to pay. Do you have any insights on that in terms of experience at your health system?
So it's a relatively new concept for the Penn Highland system, to be honest. We've been maybe live on that 6 months now, and obviously in the middle of a public health crisis. But I can say that the estimates that people are receiving seem to be much more accurate than the old manual type that we were doing prior to getting an estimator. And they're happy with that. They know going in, these are the bits and pieces. Now, that hasn't necessarily equated to us being able to collect more of it up front at this point in time, but it certainly is helping the transparency. And I think if people can understand our websites, which I think is definitely the biggest part of the challenge for folks, that they will continue to enjoy having that.
That makes sense. And I know hospitals out there like Common Spirit Health and Banner that have recently implemented the ability to set up payment plans off the estimate that we've worked with them on, and that's something that's proving to get patients more comfortable with paying balances rather than these big estimates. Like, okay, they understand what it is, but being able to set up plans off that estimate. Greg, I'm just curious. I know you at Elmhurst, you do estimation and things like that. So how have you seen any changes in this past year to your process before? I mean, Heather made a great point. It's like, tracking metrics this past year is sort of an asterisk, right? Because of the non-business as usual. But have you seen anything with the estimate side impacting affordability and patients' ability not to skip care, right? So what can you add there?
Yeah, no, I think unfortunately I don't think we've seen the fact that we offer it. I don't think we have seen an increase or decrease in that sense. I think what it allows for is for those patients who actually go forward with it have a very clearer understanding of what their financial responsibility is, and so there's less efforts on the back end to collect and work on it because they understand what they're getting into. I do think, going forward, we hope that to get better, but right now I think that's really been the big benefit of allowing the estimations.
And Chris, and I'm sorry this wasn't a planned question, but I'm just curious, does affordability impact families at children's hospitals as much Do you still see the same trends that you read elsewhere, or is it different because it's kids?
It's a little different, John, but what they really like is the access piece. Is that keeping in mind that these are the groups, these parents are the groups that are generally doing everything online and doing everything digitally. So they want to be able to interact with us that way. So it's probably more of an access and how they can schedule, and they don't want to have to wait and things like that. The pricing is a little bit, I mentioned before, we have two large hospitals competing with us. They happen to both be relatively expensive hospitals. So we do actually get a little bit of that benefit because of the pricing side of it. I think to your question, it's probably a little bit less than it is in the adult world because you have less choices and it's your kid. And there aren't, when you think about the really expensive things in the adult world, they don't typically exist in the kids' world. The expensive things in the kids' world are your cancer and some of your childhood diseases, and you kind of don't really shop those things around. You go where you think you're going to get the best care for your kids.
Right. Yeah, I think it's always important to keep the bigger context here for this, for sure.
Mm-hmm.
Well, this has been tremendous, and before we get to questions from the attendees here, just wanted to go around with each of you and see if you have any key takeaways that we've talked about for action items or insights that you'd give for revenue cycle leaders on the call today who are also weighing these same issues. Anyone like to start? How about Heather? Would you like to start?
Sure. I always go back to the fact that I think we need to focus on our core strengths. So for Penn Highlands, we know rural healthcare, and so we try to keep our folks close to home, and we'll do anything we need to do to get that care to them. The other thing that's really important, especially for rev cycle leaders, is to don't lose sight of the fact that you have to have your cash flowing. I know, spoken like a true CFO, but that's pivotal for everybody. As the pandemic continues, we have to continue to have money coming through our doors. So everything that we do in the rev cycle is important to keep all those clinical folks running.
Good takeaway, good insight. How about Chris?
I think Heather's dead on. I think that when she says do what your sweet spot is, what you're good at, is that you also have to understand your consumers. One of the mistakes we made when I first got here was trying to take some what I call adult business office practices and put them in the pediatric world. They didn't work because my consumer's different. And so we had to retool and rethink about that component of it. And so it gets back to, I need to focus in on what's good for my consumers, and I have to understand my consumer base because some things work and some things don't. And so you got to really understand that and focus your attention there. And I agree too with Heather with my CFO hat on, is that I got to drive cash. At the end of the day, I got to get cash in the door. So whatever I can do to make it easy to do that, I will do it. Chasing down people that are overdue, et cetera. The money you get out of that is a really low yield, and so making sure you get on those things on the front end, even to the extent of giving bigger discounts for cash payments, is better than trying to figure out I'm going to get more, but I'm going to try to chase them for 180 to 360 days. It doesn't seem to be where you get paid off.
Right. I'm going to put these financial leaders on the spot here real quick. So give me priority 1 versus priority 2. Increasing cash or lowering costs? What's more important going into 2021? What would you rate that, Chris? And if you want to say same, that's okay.
Lowering costs of what? You mean the cost of healthcare? The affordability piece?
I'm talking overall, your goals for 2021, everything that's impacted. Are you focused more on increasing cash for the system or lowering costs this year?
Increasing cash.
Heather?
Definitely increasing cash.
And Greg?
Yeah, no, most definitely ours. And from the rev cycle standpoint, it's definitely to increase as much cash. I have a bigger impact on that than lowering my costs because I can't control clearly all the costs of the hospital. So it is increasing cash.
Right. And Greg, what is some key takeaways that you have before we turn to Q&A?
Well, yeah, no, just I think they, clearly Chris and Heather hit it. What I would just add is, so when we look at our, our care models, we also look at how it supports the physician too. I know none of us has lost fact of that, but we need to, make sure that it supports the physician while improving, the consumer access. And then lastly, we didn't talk about this, but I think, with all these changes in terms of COVID and how we do things, I think we got to make sure that we develop and implement, the right payment models with our managed care providers and so forth. It's a new era in terms of how we get paid for some of these things. So I think, we just got to keep that in mind too.
Excellent. Thank you so much. And we'll turn it to Q&A now, back to the Beckers folks.
Awesome. Sounds great. Thank you, Greg, Chris, Heather, and John for that fantastic presentation. Like John said, we're going to start today's Q&A session. So if you haven't already, please submit any questions you have by typing them into the Q&A box that you see on your dashboard. We're going to try to get through as many of those questions as we have time for before the top of the hour. So first couple of questions that are coming in are around, remote working, AI, propensity to pay. So what we're going to do is sort of have each panelist weigh in kind of as a rapid fire response. And so what we'll do is I'll direct the question to Greg first, Chris, then Heather, and finally John if he wants to weigh in. So that's the order we'll go in today, and I'll kick off with the first question. So one audience member is wondering, what % of your business office staff are currently working at the office versus still working remotely? And then what % do you expect will remain remote? So Greg, we'll start with you.
Yeah, so there are strong restrictions here in the state of Illinois in terms of what we're allowed. As a rule, we didn't have many folks in the business office work remotely. Certainly COVID put us there. And so we have allowed, due to the pandemic, that pretty much 100%, and I know it's not a full 100% because there are work tasks that have to be done on site, some of the scanning and paperwork. So there are a handful of people that are still in the office here with me. But for the most part, we're pretty virtual in that sense from the business office. Looking at the patient access side, registration, you can't be virtual, so they're all there, but we actually sent most of our call center from a scheduling standpoint to be able to work from home. And we're monitoring that, and we're evaluating whether or not we stick with that. Our results, and because we have great KPIs that we can monitor, our results look good, so we're going to keep it as an option for our staff. And then on the HIM front, all our coders were already, work from home, so that wasn't really a change for them. And then the folks that were here, we really did look at, because of COVID, how do we move more of those folks home? And again, just like the business office, there's a handful of people that just have to be here day in out for they keep me company just to keep the lights on.
Thank you. And Chris, what about Dayton Children's? How many folks are still remote, and what do you plan for the future?
I think we're really close to Greg, is that your business office is largely at home. And I don't, when they come back, I would bet that they come back more at about 20% rate. They may all come back at some point, but maybe only a day a week, so we can get back in and get some team building. But I don't see us coming back 100%. The patient access folks, to the extent we need them here, they're here, depending on what sites they're working on. And then the scheduling, medical records, those folks are working from home, and we're actually seeing really good productivity and really good results at home. So we have no real, we're not in any big hurry to bring people back, and they all seem to be working really well. They're all very appreciative of being able to work remotely.
Agreed.
Absolutely. And Heather, what does your situation look like at Penn Highlands?
So we're probably the oddball in a lot of this. Everybody's still here and has been the whole time. The only ones that have ever been virtual have been our coders, and they continue to be virtual. But as far as our business office staff, they have remained, they're not in the hospitals proper. They're in an outside building where we felt they've been pretty safe. We were largely sheltered, honestly, from the pandemic up until the last couple months where the spike has hit us locally. So we've been able to keep everybody on site and keep everything flowing that way.
That's really interesting and a great question from the audience too. So I just want to shout out that. The next question is about AI. And an audience member says that they're really intrigued by Teladoc's purchase of an AI company. And they're interested in hearing how all three of you are exploring AI and incorporating it into your organization. So we'll start with Greg again on this. And then if Chris, you want to weigh in, and Heather can wrap up as well. We can go in that order again.
Yeah, I mean, I wish I had a lot more detail to share with you. We're looking into it and where we can. We're still evaluating how we would use AI and machine learning. I mean, again, being on Epic, we're trying to use as much automation as we can in that system, and then bring on whatever tools that we can't do in Epic that would help us automate it. But we're probably still learning. We actually have a committee specific to this to kind of talk about what should be some of our next steps. But it is something that we certainly are looking into and want to get into, personally myself. So, but unfortunately, I don't have finer details on it for you.
Yeah, and Dave, we've taken a look at it. There's a company actually down in Columbus called Olive. Many of you probably heard of. And we've explored it with them, but quite honestly, we're not at a size where it makes it scalable to do something like that. I think that the AI work and the cost of it really fits well in some of the larger shops. For us, we're not big enough for it to really help us from that perspective. I mean, we're continuing to look and see what we can do, but right now we are continuing to, I think like with Greg, we're an Epic shop, we're doing everything we can electronically and using their tools, but right now we're not headed down the AI path.
Right, more in that exploration period as well. And Heather, what about you in at Penn Highlands?
So we've also vetted this through a couple different companies, have just recently settled on a company in the West Coast that we're going to work with to do our prior auths through AI. And we're also going to do something a little unique and have them build an AI process around some manual charge input and movement within patient accounts on our outpatient footprint to be able to repurpose those FTEs and have them do something at a higher level. So that way we kind of break even on the initiative. But I agree with the statement that if you don't have a huge footprint, it's hard to get AI that's cost effective for us. So this is the way we've been able to work this out.
Yeah, absolutely.
Yeah, this is John. Just one really quick thing to throw in is one of the things that with AI has been impacting is reducing the number of calls and interactions with the call center and the business office staff. So we've been working with a company called Ivy that's integrated with our system that does full chatbot that can even authenticate for making payments and showing estimates and payment plan offers and things like that that our customers are getting access to through that. So that's been something that one piece in the revenue cycle that has been of a lot of interest.
Thank you, John. And yeah, just really great insight across the board on that question. And just looking at the clock, we have time for one more. And this question is about patients' ability to pay. I know, Heather, I think you talked about loan programs throughout the program, and they were brought up a couple times, but an audience member really wants to know, what are your thoughts on patient loan programs, both for existing payment plans and also ongoing payment plans as a alternative for patients? So we'll start with Greg, Chris, and then Heather, if you want to add anything on at the end.
Yep. So I actually like the idea. We don't do it today. We actually just changed banks last year to PNC, and we're talking with a company that's affiliated with them. So we're looking into it. I think it'll be something that we will potentially offer out there. But today we're not doing anything from that standpoint.
Got it. And Chris or Heather, anything to add on that question?
I don't. I'll be honest with you. I've just never been a big fan. I've never found a structure that I felt like worked. I mean, my ideal thing would be on a patient list, I want to give it to a bank and I want to be out of it. And as long as there's recourse and I have to be in the middle of it, it just creates one more administrative burden to try to track. So I just need to keep it myself and figure it out, or it needs to go to somebody else, take them off on a non-recourse basis.
Yeah, and I don't have anything additional to offer on that. I'm in complete agreement.
Well, thank you all so much for taking those questions, and the audience too for being so engaged. Got some really good, interaction as well. So I just want to big thank you to everyone else. And John, before we wrap up, I want to throw the floor back to you. Any final thoughts today?
No, I just want to thank Heather, Chris, and Greg for the great insight and taking time out of your busy schedule, and really everybody, all the providers on this for doing the same. So I think it's been a crazy year, and I think it's not only taught the hospitals how to do some things differently, it certainly has educated, the vendors serving them, in terms of how to change their business models as well.
Great, and I'll step back as we echo that gratitude for Greg, Chris, and Heather, and also Flywire for sponsoring today's webinar. So everyone enjoy the rest of your day, and we look forward to having you join us for future webinars.
Stay healthy,
everyone. Be safe.